All right, we're going to get started, and people can continue to join as we go along. So I'm just going to recap again. Welcome, AMSA fam. My name is Ashley, and I am one of the members of the Medical Education Action Committee. I'm a fourth-year medical student at Yale. I want to welcome you to the beginning of our community curriculum webinar series. This webinar was really born out of a personal interest of mine in thinking of ways we can discuss topics related to the social determinants of health in national medical school curricula. I just want to state that the purpose of this webinar is to encourage respectful discussion on social determinants of health related topics and its role in medical education. It is in no way meant to be exhaustive or prescriptive. These are not official AMSA recommendations, but rather a chance for us to bring experts into the field to discuss some of these topics. It is my privilege to welcome our guest speaker, Dr. Ava Black, who's here with us today. Before we begin, just a few housekeeping notes. So that we can best hear one another, please mute yourself when you're not speaking. Also, if you have a question at any time during the webinar, feel free to type it in the Q&A box. We'll most likely address it towards the end of the webinar. But yeah, all right, let's get started. One second. So, Dr. Black, can you begin by telling the viewers a bit about yourself, including your medical area of training, name of your current institution, and your position and roles at that institution?
Absolutely. Thank you so much for having me. I'm so delighted that this is even an event that's being the focus of this webinar series. I think that's really exciting and encouraging that more and more people are having this topic on their radar. So I'm really delighted to be part of the conversation. So I came to Yale back in 2013. I currently work as a faculty member in the Yale Primary Care Residency Program. So I'm in internal medicine, and my focus is really outpatient. So really caring for urban underserved primary care patients. And that's about 50% of my job, 50% clinical. The other 50% is really mixed between educational and administrative responsibilities. And so I have the privilege of serving as the Associate Program Director for Diversity and Inclusion. And as part of that job, I get to think about ways in which we can incorporate the social determinants of health into our curriculum for the residents. I also do a fair bit of medical student teaching as well as faculty development on issues around bias, stereotypes, discrimination, equity, and I've had a lot of fun kind of thinking about how to train up our faculty members as well to make sure that this is a consistent message that we're passing on across our institution. So it's been a really interesting journey for me just professionally to think about the area of diversity, equity, and inclusion, and I found a great home here at Yale doing that. So it's been a lot of growth in this role, and I'm really excited to share more with you.
Thank you so much for that. So can you talk about your interest and work in the field of social determinants of health? I know you touched on it briefly, but how it was developed and how it's changed over time.
Yeah, so I think for me, my journey into medicine was an interesting one. I think, to be generally honest, starting out when I wanted to be a doctor was probably a very superficial kind of dream and vision that I had, just more so around related to, I like to help people, but it didn't have much substance behind it. And when I went to college at Princeton, and there my eyes were really opened around social determinants of health. And I majored in sociology and minored in African American studies. And I was pre-med at the same time, but I actually remember having this somewhat of an internal crisis because I was realizing that the things that got me really passionate in my coursework weren't related to biochemistry and organic chemistry. It was really sitting in a class on race and medicine, thinking about anthropology, thinking about political science and race and gender and socioeconomic status, and how those things intersected. So that there's actually a time where I thought, maybe I don't want to be a doctor. Maybe I want to go into something like social work or teaching and help address some of these inequities. So what ultimately happened is through my sociology classes, I ended up learning a lot about these social determinants of health. And I realized that as long as I could work in a pocket of medicine where I was feeling like I could tangibly make a difference to patients who experience worse health outcomes and worse access, for me personally, that would be very fulfilling. And so that's kind of how my interest in primary care grew, because I felt like I really wanted to be on the ground. I wanted to understand what patients were experiencing. I welcomed the idea of bringing various elements like transportation issues and housing and food insecurity and all of those things. I wanted that to be part of my relationship with the patients and part of what we were working on. And I didn't want them to feel like those topics wouldn't be welcomed in the clinical space. And so that's kind of how my interest in primary care and urban underserved primary care specifically originated. And I think what has developed over the last few years is that I've recognized that workforce diversity, which is this term that really applies to not only thinking about patient equity, but also thinking about how things like race and gender affect us as healthcare professionals. I really see those two things as going hand in hand. The fact that our healthcare workforce isn't anywhere near as diverse as the country that we live in. There's really good data to suggest that having a more diverse health workforce actually improves care for patients. And so I've gotten a lot more interested in thinking about how we can address that workforce issue, in addition to thinking about things from the patient perspective.
Oh, thank you so much for sharing that. It's very insightful. So when discussing social determinants of health, I believe terms such as social medicine, social justice, social determinants of health, social needs, and social risk factors are commonly used, sometimes interchangeably. How do you define these terms and their relation to one another?
Yeah, so I think they're all interconnected, and I appreciate distinguishing them, because I think a lot of times whenever we talk about issues pertaining to diversity and equity, it is important to have a shared mental model around terminology. And so I think social medicine is honestly very similar to what I was just describing, what I was exposed to in college without necessarily knowing that term. I think it's almost this framework. There's this study, this interdisciplinary way of looking at medicine that says people aren't just their biology. They're also their psychological factors, their social factors, that have a huge bearing on their health. And so it does borrow from disciplines like sociology and anthropology, things that I was exposed to. And those frameworks were really important for me in learning to contextualize medicine, because unfortunately I wasn't getting that content through my pre-med required classes. And so I think that's how I kind of think about social medicine. In terms of social determinants of health, I think that's a number of different factors that all have a huge impact on the way that we live as human beings and our health outcomes and our healthcare access. And so a social determinant of health can be positive or negative. I think we forget that sometimes. So, certainly we often, as we appropriately should, shine the light on social determinants of health that lead to worse health outcomes, but there are also protective social determinants of health, like a high socioeconomic status, right? And so all those factors really interact with our healthcare system and make a huge difference on the individual level as well as the collective level. And then I think when we think about social risk factors, those are the things we see all the time that really, can lead to these really harmful consequences for our patients and put them at increased risk of morbidity, mortality. And so commonly we think about transportation issues, we think about housing, we think about food deserts, all of those things that can really play a huge role. And, I see also this idea of social needs, which comes up a lot. And that I think is more at the ground level, the concrete aspect of, if my patient needs a medical transportation service to get to the appointment, that's one medical need, and I can address that perhaps in a visit. But doing that in of itself in isolation, is really going to fall short to understanding their whole kind of social ecosystem that develops their health. And then lastly, this idea of structural competency. So I think the way that I like to think about that is also this contextual framework that's really taken off running in the last several years to help educators think about how we can, make folks understand as medical trainees that medicine isn't just the clinical, it's not just the biological, right? And so we have to understand that what happens to a patient is not just about what they're doing on a day-to-day basis, it's also around the structures that exist, whether you're talking about, the transportation realities, the lack of sidewalks in one's neighborhood, the disparate kind of trends that we see in terms of incarceration. All of those things have a huge impact on how someone is going to thrive. And so it's shifting the focus, I think, from individual activities, behaviors, and just making the point that all of us live in a certain social ecosystem that can then create these structures that impact health. And so I think it's an educational model more than anything with structural competency.
Thank you for describing that so beautifully. As you said, these terms do really interrelate. I feel like you were able to very clearly state kind of how we can think about them and approach them in a clear way.
Great.
So it is known that the US spends a large amount of money on our healthcare system compared to other countries with similar GDP. And that despite this spending, our national health outcomes do not necessarily reflect these financial investments, and that health disparities exist across our country. Furthermore, many in the field of medicine note that the practice of medicine and medical education, as you stated, kind of focus on this provider-patient level rather than these upstream structural and systemic factors. Many point to this focus as a reason why many of our health outcomes are not as ideal or are a bit suboptimal. As a result, numerous national medical organizations have called for improved education on the structural and systemic issues that play a role in disease prevalence and outcome. With that in mind and your professional experience, what, if any, do you think is the role of medicine in introducing and teaching kind of some of these concepts we discussed and providing physicians with competencies in these areas?
Yeah, so I thank you for bringing this to light, because I think it is absolutely and indisputably the responsibility of medical educators to have trainees be thinking about these important topics. And I think we are doing a real disservice to people that we're training in medicine if we are teaching them about biology without helping them to understand that biology is just one aspect of a patient's health, the patient's health outcomes, the patient's health access. You know, I always think about, you know, the primary care provider. If my patient is coming in and, you know, their electricity is off in their house, I think how on earth are they going to be able to, you know, follow these very complex plans that I'm putting in place, or even prioritize that when there's these very fundamental things that are going awry in their household and in their communities that prevent them from doing certain things that would optimize their health. And so I think it's really counterproductive to be a provider who doesn't think about social determinants of health. You know, I think we have this culture sometimes in medicine that really prioritizes the evidence-based aspect of things. And certainly we all want to be evidence-based. That's appropriate in the guidelines that we give and the recommendations we make to patients. But we have to understand that the evidence-based medicine actually goes hand in hand with social medicine. And I think what social medicine does is it just provides this base level understanding that biology is just a piece of the whole pie. And so I think to have someone come up in medical training without understanding that, you know, being an expert in, you know, congestive heart failure, but not understanding how a patient living in a food desert, being on a fixed income where they're not able to have ends meet, is going to impact your plan for them to follow a low salt diet and to exercise in their neighborhood where perhaps it isn't safe for them to walk around or jog. And so we have to be really mindful of that as providers. And I think the only way we're going to learn to think in those terms is if it's part of our formal curriculum. And I think certainly we can get this education informally. You know, I think most of us who go into medicine are naturally reflective people. We like to think about the care that we're providing. And so having interactions where you see patients and you see their difficulties and their risk factors hopefully prompts a lot of people to think about these issues. But I don't think that's enough. I think we need time and space within our curriculum where we are addressing these issues all across medical training. So I think that includes at the medical student level and residency, and even continuing on as faculty, because, you know, as faculty, we're certainly not, you know, immune to going back to a purely biology-based way of thinking about patients. So I think it's absolutely the responsibility of our medical education institutions to be promoting social medicine and helping our trainees to grapple with these difficult topics.
Thank you so much for sharing that. I feel the same sentiment, where I would love, as a medical student, to have more of that within the curriculum rather than it be my more initiative to have to go find those opportunities. You kind of already answered the question on like where within medical training can this occur, and you mentioned kind of on all levels it should really be being addressed, whether you're a faculty, medical student. So I'm going to focus a bit on the medical student education. So many schools across the country have implemented various initiatives to teach social determinants of health related topics in medical school curriculum. In an effort to kind of map out characteristics from publications about these various teachings to students, researchers at Northwestern School of Medicine conducted a review of the literature over a 6-year publication period. With a final sample size of about 22 articles, they described the following 7 course characteristics: content and topic of these courses, education methods, the timing of these courses, the educators of these courses, the learners who who participate in the course, and also the evaluation and funding of the course. Are there any certain topics that you think, Dr. Black, are crucial to include when teaching kind of things about social determinants of health to students?
Yeah, I think it's all of the above. I certainly think that one issue that I notice is that oftentimes there aren't that many people necessarily in academia who feel comfortable providing education on this topic. And so even if there's buy-in that social determinants of health is a crucial part of the curriculum, the question then becomes, who are the people who provide the education? And I think this can really be an area where sometimes there's a disparity where people who identify with underrepresented background are more likely to engage in issues around social medicine. And so the burden of that education can really fall on underrepresented educators, which I think is something that we really need to work on. And so, I think it really needs to be this like train the trainer model. So, I think it sends the wrong message, certainly, if we only have people who come from an underrepresented background or who have themselves personally experienced social determinants of health be the people who are pushing this message forward. And so I think that's one of my interests, is kind of thinking about how to develop a team, how to have this collaborative community where there's baseline buy-in that, hey, this is an important topic. It affects what we do on a daily basis as providers. And also the team that provides the education really also needs to be diverse. And, I think some of us, like myself, have had, undergraduate training in sociology, and that certainly helps sharpen the lens of thinking about these things. But I think it's also the type of content where if you get adequate exposure, then you can also become someone who then passes the message on to trainees. So I think that's huge. I also think, there's not that much literature in general, speaking to the concept of, evaluation of what are best practices for teaching around health disparities, social determinants of health. And I think that's really still largely a big question mark. There certainly have been studies that look at learners' responses and preferences when it comes to this kind of teaching. But I think we need more data to help us inform the way that we engage with these topics, because they can be difficult, and people come from very different walks of life, very different perspectives and different comfort levels, even in having these kinds of conversations. I think something certainly that I find is that somewhere along the line, topics like race and gender and socioeconomic status became this taboo to talk about, even though they affect a lot of what we do in healthcare. And so I think part of it also is just culture change within the overall culture of medicine to help us become more comfortable about having these conversations openly without a sense of shame, and just kind of engaging with it and learning to do better.
So thank you so much. You touched on a couple different great points. So I'm going to kind of attack each one separately. So with educators, you mentioned that it's difficult to really get that group that has the experience to teach. And I think what the study found was that a lot of the educators of these various courses had very teaching experience in social determinants of health, and also very few of them incorporated some community educators who were more involved in community engagement or were more established at local community resources. So kind of with that in mind, you kind of touched on this. Who or what groups do you think should be coming together to structure this course, and who should actually be carrying out the teaching of this course?
Yeah, so I think that's a great point, this idea of community engagement, right? Because, the experts on the community are often the community members themselves, right? And we think about that certainly with community engagement initiatives, but I also think it's important for educational initiatives that reflect the various barriers that the community is facing. And so absolutely, I think, there's so many local organizations oftentimes that are devoted to promoting the wellness of certain communities. And I think we can draw upon those community leaders, those community organizers to help inform the content, and in some cases to serve as an educator. I also think we have to be important about not overburdening people who already, have a wealth of things to tackle in their own communities. And so it needs to be a partnership, certainly, but a partnership that mutually benefits all parties. And so I think that's why I think it's especially important that faculty members at an academic organization really work on that faculty development piece so that there isn't just this small pool of people who feel comfortable providing this content, but that there are a number of folks on the faculty itself as a body that can really engage in this conversation and help to move the message forward. I also think that there's a role for trainees, certainly, you yourself, Ashley, are very interested and also very well trained on this topic and have a lot of expertise that your colleagues can certainly learn from. However, I also, with anything like that, I think it's important, again, to make sure that we're not burdening trainees. And so, students and residents, their primary job is to learn and to grow. And so in certain situations, it may be appropriate to pull alongside a trainee for a collaboration. But I do think that it's important that we don't have some of this education kind of falling on the backs of people who just happen to be interested in these topics.
Yeah, no, that makes 100% sense. And we also touched a bit about this, but many of the different courses that this study found included an experiential learning component or a community engagement component for the students in the course. Literature has shown that community visits and placements can assist the student in developing communication skills and appreciation of non-medical community health support and an increased understanding of community health. Furthermore, research has shown that students engaged in service learning showed an increase in the degree to which they felt aware of community needs, believe they can make a difference, and were committed to service in the future, and that the communities involved in service learning have shown a positive effects in their client population. With that in mind, how could you imagine the particular structure of incorporating experiential learning and experiences in a course for medical students? What other components of the course do you think should be included, like didactics, research, clinical evaluation, reflective writing, et cetera?
Yeah, so again, I think it's really all of the above. I think you can't kind of overstate the importance of students getting out in the community, developing partnerships with community leaders, actually spearheading a project. And I think, as I sort of alluded to earlier, any project that a student engages in, I think, should really be informed by the needs of the community as defined by the community. And I think sometimes in academia, we can have the tendency of trying to do this outreach where we come in as the experts, where we're going to then help the community and save them from the issues that they're facing. But oftentimes, as I mentioned before, the community not only knows the barriers the best, but they also often know the solutions. But for whatever reason regarding kind of disempowerment or resources, they may not be able to have those recommendations be something that they personally can affect change in. So I think our job as students, as residents, as faculty members, is to come alongside community members, engage with them, and learn from them, and then, assist in ways that we can. So I think the research is an important piece. Research, again, should always be directed at helping the community. It should be a bi-directional relationship, not just us promoting our scholarship in the community. I know of various structures in our institution where folks actually say, you can't actually do community engaged research if you're not planning on feeding your results back to the community and describing your plan to address whatever research findings came out of the study. So I think those things are really important, and I'll leave it at that for now.
No, that was such a great point. I think some of the studies found that a lot of the students who would go into different community resources would have their projects kind of be determined by what the community needed. For example, I think at Mount Sinai, I believe they worked at a homeless shelter, and students were made projects based off of what the leaders at that organization thought was needed. Along that point, a lot of the time and durations of these courses varied extensively, also depending on how much community engagement they wanted. Those that wanted longer community engagement projects extended over many years. Some were over clerkship periods, so that were short in duration, a few weeks. Some were just a week or so. Do you have any recommendations on kind of when and where in medical school curriculum such a course could exist? Should it be for earlier students, later students, across the years in some form? What are your thoughts?
Yeah, so I think it's really important that with issues surrounding diversity and equity, including social determinants of health, that we really take a longitudinal approach. I think, it's a really hard sell to think that, one-time workshop over the course of 4 years is going to do the job in terms of helping people to understand these very complex interplays of social determinants of health and health disparities. That's just not enough. And so we need to be engaging repeatedly with this material. I think this is an area where planned redundancy can actually be very beneficial to students because, you know, as someone who does a lot of diversity education, even if I run a similar kind of content for a workshop, the workshops always change depending on who's in the room and what is shared. And so I think oftentimes we learn so much just from understanding each other's experiences or just by hearing someone else reflect on their experience with a patient. So I think it certainly has to be throughout the curriculum. I think, you know, as a starting point, you know, certainly we have many structures with an onboarding process, both in medical school and residency, where there's an orientation for interns or, you know, there's orientation for medical students who are coming in as first years. I think that should be a place where some of these topics are introduced and discussed in a workshop format. I think it's important that people hear from leadership of an institution that social medicine is part of the way that we conduct care and as part of the way that we operate as providers, because I think that message coming from the top is really important. And I also think that, you know, there's several kind of structures that already exist within medical training. You know, I think a lot of first-year medical students have some kind of course that's somehow related to, you know, on doctoring, being a doctor, like learning those kind of essential history taking, physical exam skills. I remember I certainly went through those. And I think introducing social determinants of health at that crucial stage, or just starting to kind of grapple with understanding what it means to be someone's provider, I really think it should be in tandem with learning how to take a history, because taking a history effectively is only going to be optimized by having a nuanced understanding of social medicine. So I think there are a lot of opportunities to engage with this material, and I think our understanding of it only deepens the more we talk about it.
Yeah, no, I think that makes 100% sense. So with that kind of in mind, some of the programs that the study found, a lot of them actually were limited to a certain number of students and or required an application process. What are your thoughts on kind of such a system that teaches to a select few? Do you think it could, you know, really select for students who already have experience and some basic understanding of such concepts rather than students who haven't had such exposure? Or do you think there are certain circumstances where it is appropriate for a more selective course offering?
Yeah, I think that's a great question. And I certainly think that people, you know, students who may have a particular interest in this area should certainly have an opportunity for advanced learning in it. I think we can adopt a similar model as we might think about with distinction pathways, or, you know, people graduating with a distinction in a certain area, almost like a minor. I think the same thing can really apply to social determinants of health. But with that, I think it's really important to stress that every student, regardless of their level of interest in social determinants of health, I think it's really important that there are mandatory trainings, mandatory workshops, mandatory reflection pieces, mandatory research experiences within the community, all of those things that are required for all students. And then perhaps there are special opportunities, additional projects, more of a deeper dive for students who identify as perhaps wanting to make a career that focuses on social determinants of health, or for whatever reason want to get extra training or exposure. But it certainly shouldn't be an all optional kind of format, because I think what can happen then is that people who are already fairly well versed or interested in understanding medicine through this kind of biopsychosocial lens, they become more expert at this. But then people who maybe don't see the need for this as much continue to be able to avoid these issues and not bring it into their clinical practice, which I think is very problematic. I think I see this not necessarily in terms of health, but even in some of the bias training sessions that I run at our institution, where if it's an optional workshop, people who come are often people who have already spent a lot of their personal time kind of thinking about their own bias, which we all have, already thinking about ways to improve themselves and become more engaged in diversity and equity. And so in a sense, it becomes this model where, you know, we're preaching to the choir, but we're not necessarily bringing in people who perhaps have a different framework that they're operating in and need more education about why it is so important to think about things from a social medicine lens. So I think in short, it's important that all students have some kind of exposure longitudinally throughout their training, and then there's extra opportunities for those who want that extra exposure.
Yeah, no, that makes complete sense, having both of those two systems. I know you already mentioned this a bit before, but kind of deciding how to evaluate such a course that it's meeting its goals, evaluating the students of those courses can be very difficult. I think even within this study, they found a lot of the evaluation was effective changes by the student, how much, they thought that they had grown in their skills in advocacy, their views towards social justice, and then there are things towards their views towards the underserved, or kind of a lot of how they evaluated it. Only a few had a more clinical evaluation in terms of OSCEs or going back to the community programs that the students interacted and having evaluations from those community educators. So with those kind of differences, how would you structure assessing kind of competencies of understanding of social determinants of health among students who participate in these various course initiatives?
Yeah, I think that's tough, and I think you point out a really kind of hot area in terms of kind of future directions for research, because I think honestly, with the literature that's out there, we're not really sure what the best practices are for evaluation. I will say that as with most things, that I think evaluating social determinants of health, you really kind of need to incorporate multiple modalities. And so, certainly the attitudinal component, meaning, how does a student now feel about social determinants of health? How are they self-assessing their knowledge? I think there's a role for that, but that's only a piece of the story, because if someone feels more comfortable with these topics, but it's not actually changing their clinical practice, and I would argue that, we haven't exactly accomplished our goals in introducing a social determinants of health curriculum. And so I definitely think that direct observation, as with many areas of medical education, needs to apply here. These scenarios are so nuanced, and it's hard to, make a 5-point scale that assesses someone's skills in these areas. But I do think that as educators, observing someone kind of navigate the difficulties of, a patient who's presenting with a common chronic disease like diabetes or hypertension, and simultaneously dealing with transportation difficulties or intimate partner violence or incarceration issues. I think there is a way to structure even the communication that's used, the questions that are asked, the recommendations that are made, and do the recommendations take into account all that the patient has just shared about their social situation, or is the recommendation just go up on your insulin by 3 units, right? Because certainly if someone is hearing a history, but it's not reflected in the plan, to acknowledge that they've been heard and understood, and the plan usually should be adjusted in that scenario. And so I think probably the best way to evaluate some of these curricular formats is to directly observe students and give them real-time practice. So all this has to do with emotional intelligence, which I think is, another kind of interesting area that we're thinking more about in medicine, is how do we teach these skills? How do we assess these skills? Because it often comes up when it comes to professionalism and medical education is, how well are you able to understand the emotional status of a patient, understand what they're going through in light of their social ecosystem, and then have that be incorporated into the way that you provide care.
Yeah, no, I think that makes having this multi-modality approach of assessment would really help address all those areas. Is there an understanding of it? Is there an actual use of it? And is there a reflection on the part of the student? And then one last kind of characteristic that these researchers looked at was kind of funding for these courses and how they're supporting the teachers and the structure of the courses. They found a couple of different sources of funding: government grants, kind of endowments, or sometimes they just were not really reported, they were kind of university funds. But majority of these kind of used funding that was outside of traditional institutional medical education funds. So how do you think funding plays a role in the creation and sustainability of such education and initiatives in terms of getting teachers and really making a robust course?
Yeah, I think that's huge. I think how we allot money often speaks to our institutional priorities. And so I think a curricular structure is really vulnerable if there's not longitudinal funding, if you're sort of dependent on, a year-to-year grant from somebody, organizational allocation. And so I think it's very important that the institutions that we work in, speak to the value of diversity, speak to the value of social determinants of health by allotting funds. I think they should come from the institution. And I think when they don't, that can really send a confusing message in terms of how much the institution actually does value diversity or prioritizes this content. And I think the issue with that, as you mentioned, can really fall across a number of different areas where, if you're struggling with funding or the source of funding is uncertain, then it's really hard to have consistent educators to teach the course, to respond to feedback that you may have gotten from a previous session, and to make sure this is kind of a streamlined core part of any curriculum. It's hard to plan ahead if you're not even sure if you're going to be in existence from academic year to academic year. So I think that's huge. And I also think that we have to avoid the concept of volunteerism when it comes to education and diversity, because I think sometimes it can be a thing that's kind of tacked on. We talk a lot about that in thinking about the concept of minority tax, which is this idea that oftentimes for, faculty members, or honestly, even residents or students who are from underrepresented backgrounds have this disproportionate burden of providing education, of working in diversity and inclusion for the institution that isn't compensated or sometimes not even acknowledged appropriately. And so I do think it's very important that any organization in medicine or beyond, if they're saying that they value diversity, that has to come with consistent funding to really back up that claim. So I think that's key, and I think it's a lot easier to grow and have a strategic vision even around how a curriculum can expand from year to year when funding is secure.
Yeah, no, the strategic vision is I hadn't thought of it in that way, but yeah, to really get the passion and the thought to be in there, there has to be an idea that there is existence for that, there is funding to support that. So thank you so much for kind of touching base on these couple of topics. Just to kind of open it up a bit more, do you have any recommendations or pieces of advice for medical students who want to advocate for curriculum change at their school, whether about this or other topics that they want to bring into their curriculum?
Yeah, so I think one thing that's huge is, finding your allies. And so I think something that can be difficult sometimes about being a medical student is that it can feel disempowering. You might feel like you're at the bottom of the totem pole and that you don't have much pull. But I think sometimes we underestimate actually how much students do have influence with their institutions, because institutions are in the business of keeping their reputations thriving and having their students be have experienced a sense of wellness and feel pleased with the institution. That actually tends to be of high priority to many institutions. But secondly, even beyond that, I think there's usually at any institution, there are people who get it, right? Who get that social determinants of health is really important, who get that in many cases we aren't doing the best job with educating folks about these important topics. And so even finding who those people are within the institution and not being afraid to share with them that you would like to see a more advanced curriculum, you would like to have more exposure in regards to social determinants of health. And that partnership can then help to bring those conversations into the right rooms with people who may have more pull in terms of directing the content of a curriculum. So I think both of those things are really important. I also would say that, if you're here, you're listening, and you feel like you're not as educated as you would like to be on social medicine, I think one of the ways that we really learn best, even outside of a formal medical school curriculum, is just by talking to people. I sort of touched on this briefly earlier, but something I love a lot about being a diversity educator is that I learn all the time just by teaching workshops, by giving lectures and hearing people's questions, hearing them share their experiences, hearing them describe their worldviews to me. And so don't underestimate the value of talking with a classmate about some of their own life experiences, or talking with someone who seems to have a more nuanced understanding of social medicine and seeing what you can learn from that person, because I think we all make ourselves better when we surround ourselves with people from different walks of life and start to understand that our perspective is only one perspective, but we really can be better providers, I think, by talking more with each other and not being afraid to talk about things that might inherently make us feel a little bit uncomfortable.
Yeah, no, I think I've used one form of all the ones you've mentioned above in terms of trying to find those advocates, and my peers have definitely inspired me in many ways to learn more about these, to advance my understanding of these topics. So any recommendations or piece of advice for medical students who want to learn more about you kind of mentioned these social mental health in their kind of education, but also in their community, knowing kind of the specific burdens that might be more specific to their communities, like food deserts or kind of those aspects that their patients might be facing?
Yeah, I mean, I think as we kind of talked about a little bit earlier, there is nothing that can substitute having firsthand experience within a community. And I think my recommendation would be go, join a soup kitchen, go sit in on a community organizing meeting in a disadvantaged neighborhood in the city where you live, go on a neighborhood walk, and learn a little bit more about the history of, an area around the hospital that you're working at, and just come to listen, right? I think, again, sometimes as physicians in training, we're a lot better at talking and giving advice and making recommendations than we are to listening. But I think we learn so much just by observing, especially in an area where we might not be as up to speed. And so I would just say come with a sense of humility, come with a sense of service to just see what you can learn and how you can understand the needs facing the community. And I think from there, it becomes a lot easier to engage and think about positive intervention, because the foundation, the starting point is from a place where you're really just seeking to amplify the voices of the people that you have met, as opposed to coming in with our own agendas.
Yeah, no, that makes 100% sense. Is there anything else you'd like to share with the viewers before we kind of wrap up?
Yeah, I think we covered a lot. I think I've said most of what I wanted to say, but I think the one point that I would just reiterate with all of this is that, all of us could be much better about engaging with social medicine. Even as someone who, minored in or majored in sociology, minored in African American studies, does diversity work 50% of the time, I still find myself in patient scenarios where, I'm like so backed up in clinic that I'm like relying on my old habits of thinking about things from biological perspective and not doing the best job that I can do to really make room for some of the social barriers. And so I think it's important that we have grace for ourselves when we fall short, because there are so many competing demands. But I think my hope and I think what really inspires me, even in the last several years that I've gone through my own residency training and then joined the faculty, is that I hear more people talking about these issues in all different kinds of formats. And I think that in and of itself is a huge step forward. And so just don't sit on the sidelines, engage, raise your hand and ask a question, make it a point to have a conversation with someone that you wouldn't normally have a conversation with. Don't be afraid to ask your patient a question if you feel like you don't understand what it's like to be in their shoes. I think that kind of sums it up, is just kind of engage.
And thank you so much for that advice. I agree. I think always finding ways to kind of do more and to push yourself and to be a little bit uncomfortable but grow from that is very much key in these and learning about these. So I want to open it up to you viewers. It's time for a question. So please feel free to ask either me or Dr. Black any questions. You can use the Q&A box, I believe, up top. I'll give you guys a few minutes. We have about 10 minutes or so for questions. So feel free to ask any questions that you have. We'll also leave open for questions, but just in case there's any of those who have to head out soon, just to give you guys some information about the webinar overall. So this is our first webinar series. Thank you again, Dr. Black, for joining us and for being our wonderful guest speaker. We'll be having another, our next webinar will be next week with Dr. Anita Rohr, Dr. Benjamin Howell, and their team, also from Yale School of Medicine. So please join us then. It's at 2 p.m. Information for signing up is this link. Oh, shoot, sorry. This link here. And also feel free to email me at me.research@amsa.org if you have any questions about this webinar, questions for next week's webinar, or questions for me in any way. So if those of you who want to head out, you're welcome to, but we're going to still be hanging around a bit for a couple questions if anybody has any questions. Thank you all so much.
Thank you for having me.
Thank you. I'll give it another minute for questions, then we can just wrap up a little early today. So all right, I think that's all for today. We're going to kind of close up. Thank you guys again so much for joining. Hopefully you join next week. Thank you again, Dr. Black, for sharing, giving your wonderful insights and kind of helping us tackle this issue. Thank you guys. All right.
My pleasure. Thank you.